Okay, so we basically have this course divided into 9 different lectures, and then your final for a total of 10 class periods. So what I'll do is I'll just start at lecture 1, and then we'll work through reviewing just key concepts and make sure that you guys are okay and you feel comfortable with the material. Your exam is going to be on Canvas. So what's going to happen is we're going to meet up here at 9 o'clock on Wednesday. I'm then going to take you over to the library. We'll go upstairs, and then in room G is a computer lab. And you'll go into the computer lab. The computers will be on. You'll log into Canvas. Okay. And then you will see the test will pop up. It'll say final exam on Canvas. You'll click on it to take it, and it will ask you for an access code. The access code to get into Canvas will be the answer to a question that I will give you on Wednesday. So once you answer that question appropriately, you type in that answer, that will then allow you to open up the exam. Now the exam will not begin timing you until you've opened it up, okay? So figuring out the access code, which I think most of you will get it, it's a fairly easy question. Once you figure that out, and once it opens up the proper test questions, then the timer will begin. You'll have about an hour to finish it. It's going to be about 50 points. Okay, so that's half of your final grade, and then the other half will come from the skills afterwards. Does that kind of make sense? All right, so nothing too stressful, too crazy. So let's go ahead and start. Can you guys see that okay, or I'm gonna the lights? I'm recording this as well, so I'll try to get this up today so you have this available to assist with studying tonight. Yeah, there we go. Looks good. Okay, so lecture 1, we talked about the basic electrophysiology of the heart, electrodes versus leads, how the monitor and recorder set up, and then we talked about some of the basic intervals on the ECG. So when we talk about electrophysiology, some of the major points that you need to be aware of, first of all, what are the special properties of cardiac tissues?
The discs, intercalated discs.
Well, the intercalated discs are partially responsible for some of the special properties, but what are the properties themselves? I heard one. Automaticity, good. What is that?
They can produce their own.
They can generate an action potential on their own, okay. And which tissues tend to have more automaticity? Nodal tissues, right? They have those. They're constantly permeable to sodium. Okay. What else?
They have contractility.
Contractility, good. Okay. What else?
They can conductivity.
Conductivity, good. And there's one more major. Excitability, good. All right. And then these special properties give way to some terminology that you need to be roughly familiar with, and that is chronotropy. What does that mean? What does that pertain to?
The rate.
The rate, good. So positive chronotropics would increase, negative chronotropics would decrease the rate. Good. How about, let's see here, inotropy. What is that? The strength of contraction. Positive inotrope is increased strength of contraction. Negative inotrope would be a decreased. Good, good. So positive inotropes would be drugs like sympathomimetics, epinephrine, norepinephrine, dopamine. Okay. Negative inotropes would be things like beta blockers, calcium channel blockers, those kinds of things. Good. How about dromotropy? Dromotropy, what is that? It does have to do with conductivity. Yeah. No, it's not.
Changes the
So,
Speed at which
there you go, the
conduct
speed of conduction through tissues, yeah. So positive dromotropes you conduct easier through tissues. Negative dromotropes would slow conduction through tissues. You guys good with that? All right, good. Okay, this also gave rise to the cardiac action potential, and we'll talk about the action potential as it pertains to ventricular tissues. Looks something like this. On the x-axis, I have time, and I plot that on the y-axis against the potential in millivolts. Okay, and I have 4 distinct phases. What's this phase, this flat line here? That's phase 4. What is that also known as? Is also known as the resting. And it is negative, right? It's negative potential?
Slightly negative.
Well, it's negative compared to outside, right?
Right, yeah.
Yeah, it's like negative,
Is it 30 millivolts or something?
no, it's like negative 100 something.
Oh.
Yeah, it's pretty low. What about this initial upslope here?
0.
That's phase 0, okay? What's primarily happening in 0?
Depolarization.
Depolarization. Depolarization of what?
Cardiac tissue.
Yep. Specifically, we're talking about ventricles here, right? And what is happening though, to cause that electrophysiological?
Sodium's rushing into the cell.
Good. Sodium ions are moving into the cell, right? All right. What's this this slight downslope now?
Stage 1.
Okay, that's phase 1. What's happening in phase 1? Potassium is
Leaving the cell.
moving out. Right? So I have a positive ion moving out of the cell, and that causes the potential to shift down more toward negative a little bit. And then I have the plateau here, which is known as phase 2. And why does it plateau off?
Calcium.
So calcium moves in, or you could also say that it moves out of the sarcoplasmic reticulum to initiate contraction, right? Okay, and that offsets the potassium leaving. And then I have this downslope here, which is phase 3. And what is phase 3 also known as?
Sodium potassium repolarization.
Good. Repolarization.
Getting exposed and sodium potassium exchange.
There we go. Good. Back to phase 4, the resting potential. Rinse and repeat. Now, nodal tissues kind of look like this, right? And do nodal tissues have, what phase do nodal tissues not really have?
0.
Well, the phase 0 is different, huh?
4.
They don't have a 0.
They don't have a resting.
Yeah, they don't have that they don't have a true resting potential, right? Because they're constantly permeable to sodium. Good. All right. You guys good there? Okay, so far so good. Let's talk about leads and electrodes. So what is an electrode?
The little stickers.
Yeah, it's a little sticky, right? And you have 2 types. You have a positive electrode and a negative electrode, right? And when an impulse is moving toward the positive electrode, a positive electrode is kind of like an eye, right? And when it's moving toward the eye, okay, what do we have? That's called a lead, right? A lead is either moving toward or away from an eye, so negative to positive or positive to negative. And we call that a lead. You guys okay with that? Now, when the signal is moving toward the positive electrode, what kind of deflection is produced?
Upward.
An upward deflection, right? When, instead, let me draw this, positive, negative. Instead, if the signal is moving to the negative electrode, the deflection will be negative. You guys okay with that? All right, good deal. All right. How many leads, or how many electrodes do we place on a standard 12 lead? 10. Good. How do we get, so we have 10 electrodes, right? How do we get 12 leads, though? Vector summation of which leads?
2 and 3.
Good, the limb leads. And the limb leads are also known as What kind of leads?
Not cordial,
Right, because we can do vector summations of them, because we can look at them. There we go. Bipolar. We can look at them negative to positive, positive to negative. They have two different poles. They are bipolar leads. And we use vector summation to get our augmented leads. So AVL, augmented vector left, AVF, augmented vector front, and AVR, augmented vector right. You guys okay with that? That makes sense? Okay, when we talk about the monitor, the big thing you want to know about the monitor is the paper. Okay, so you have your printout. What is on the x-axis? Time, good. And the y-axis is amplitude, right? Yeah, amplitude in millivolts. All right. What is the standard speed for paper? Standard paper speed.
1 millimeter per
second.
0.04 seconds.
How many per second? What's the standard?
Per second.
Yeah. Standard speed of paper gets spat out per second. Say it again? There you go. 25 millimeters per second. You guys okay with that? Remember, 1 millimeter is how many boxes? 1 millimeter is, right, yeah, one small box, which equals 0.04 seconds, right? 5 millimeters is a large box, and that is 0.2 seconds, right? And then you have how many of these in 1 second? 5 of them, which gives you a total of 25 millimeters per second. You guys okay with that? Standard? Also, there are two ways that we look at, two what we call filters, right? And what's your standard filter for a rhythm strip? Non-diagnostic, right? That's a lower number, right? Like, you know, 0.5 to 50 hertz, right, would be non-diagnostic. And then 0.5 to, say, 150 hertz would be diagnostic. The non-diagnostic is your rhythm strip, right? And your diagnostic would be your 12 lead. Good. Okay, good. And then we'll just finish off talking about standard intervals. You guys should have this down, so let me draw a QRST complex here. All right, so everybody's okay with that's a P wave. That's a QRS complex, that's a T wave. You've got some intervals. You've got your P to R interval, right? You've got your QRS, and then you've got your QT, right? Which starts at the Q wave and goes to the beginning of the Q wave to the end of the T wave. You guys okay with that?
Yeah. Real quick, Chris.
Yeah.
On your time frames,
Yes.
5 millimeters is 0.2 seconds.
0.2 seconds, yeah. Did I say something
You
different?
said 0.2.
Yeah,
Yeah.
it says
Right here?
5 millimeters,
0.2 seconds?
Is it just me or does that look like a 5? 0.25.
SEC, that's SEC.
That's seconds.
Oh.
It's supposed to be SDs.
I'm
Yeah.
all getting all mixed up
Yeah.
here. Okay.
Right, so 5 millimeters, large box, 0.2 seconds. Okay?
Yeah.
We're good, okay, cool. All right, that's it, that's it. It's your high yield review for your first lecture. You guys okay there? All right, cool. To lecture 2, this was primarily dealing with the sinus rhythms. All right, so we talked here about your standard way of interpreting, right? We look at what is the rate, what is the rhythm, is there a P for every QRS, and a QRS for every P? All right, what is the P to R interval? What is the QRS duration? And then finally, what is your interpretation or impression? Right. What is the preset automaticity of the SA node? 60 to 100. Good. All right. If the SA node were to fail, the junction could take over at a good 40 to 60. The junction were to fail, you could have the ventricles take over as a pacemaker Good, 20 to 40. All right, good deal. Any questions over sinus rhythms? So you've got NSR, right, normal sinus rhythm. You've got sinus brady, cardia that we talked about. We have sinus tach. And then we also have sinus arrhythmia or dysrhythmia. And any questions over any of those? Pretty standard. You guys okay with that? All right, move along. So lecture 3, we talked about atrial, junctional rhythms, and heart blocks are actually in the next lecture. But let's talk about atrial and junctional. So in this one, we added sinus rhythm with PACs. You guys okay with PACs? Premature atrial complexes, right? So they're going to have a P wave, okay? But they're going to be early. They're going to occur sooner than you'd expect, closer to the T wave, and they're going to be associated with what kind of pause? A non-compensatory pause. All right? You guys okay with that? Generally, the P waves are going to be in the same direction as the P waves for the underlying sinus rhythm. You guys okay with that? We talked about sinus rhythm with PJCs, premature junctional complexes. Again, these have a non-compensatory pause, but what can differentiate them from PACs? Yes, there's either no P wave sometimes, or inverted short PRI. I would expect you guys to know what your normal P to R interval is, your normal QRS duration, and your normal QT interval. You know, you guys, we've been doing a lot of that up to this point, so you guys should be good to go there. Okay, atrial rhythms. We talked about a flutter. You guys okay with that? And we talked about a fib. Very common, very problematic. What does it increase our risk of? Stroke, right? Or clot formation. Good deal. Let's see here. There's some special terminology that comes from a flutter and AFib, and it has to do with how the ventricles respond, or how many of the flutter waves or the fib waves are filtered out. And if the response is what we call controlled, what does that mean?
It's an abnormal rate.
Good, the rate is at 60 to 100. If it is a rapid ventricular response, yeah, the rate is above 100. Okay, you guys okay with that? We also talked about the concept of SVT, supraventricular tachycardia. That is a tachycardia where the rate is above 150. We're not sure if the SA node is in control, and we don't have enough information to tell what the underlying cause of the tachycardia is. Is it a fib? Is it a flutter? Is it some sort of junctional tach? We're just not sure. You guys?
Say 110?
150, right? 150. Yeah. You guys okay with that? Okie dokie. We also talked about junctional rhythms. You guys okay with the junctional rhythm? So, right, junctional, you will either no P wave or an inverted P wave with a very short P to R interval. The rate of your junctional rhythms tend to be what? 40 to 60. If the rate is between 60 and 100, we call that an accelerated junctional rhythm. And if it is over 100, we call that junctional tach. Good. All right. Are you guys okay with that so far? Good to go. Okay, cool. All right. Yeah, what you got?
Going back to that, like one strip we had, if AFib is less than 60,
Uh-huh.
does that assume that it is disassociated?
No, not necessarily, no. Yeah, not necessarily. If it is less than 60 and the rate, and the rhythm, the ventricular rhythm is regular, then you're looking at AV dissociation. Because if the AV node was actually working, it would be irregular, right? Because it wouldn't be blocking them all out. Good question. You guys okay there? Okay, and we talked about the heart blocks. You have a first degree AV block, and what is that? PRI is over 0.2 seconds. And we always identify the underlying rhythm, right? So sinus rhythm with first degree AV block, sinus bradycardia, sinus tachycardia, whatever. You guys okay with that? All right, we have a second degree AV block, but how many flavors of that do we have? Two. You're gonna need to know the terminology, so what's the first flavor?
Second degree ABB, Lincoln Block, or type 1.
Type 1, or a Winky Bach, or Mobitz 1. All right, all three things mean secondary type 1. All three types of terminology are valid. How about type 2?
Type 2 or Mobitz 2.
Right, second degree AV block,
BACH.
type 2, or a Mobitz 2. You guys okay with that? And then that, it gives us a third degree. It's also known as a complete heart block. Good. You guys okay there? All right. Second degree type 1, what differentiates it?
Short, long, longer.
P to R interval progressively lengthens. Good. All right. You guys okay there? So far so good? Okay, good. Let's see here. Ventricular rhythms. So we talked about PVCs. So just like PACs and PJCs, they are premature. They are not associated with P waves though, right? Not associated with P waves, they're premature, and they are also associated with a non-compensatory pause. All right. The morphology of PVCs tends to be wide and bizarre. And you can have different flavors of PVCs, right? You can have unifocal, and you can have multifocal, right? You guys okay with that? To tell unifocal from multifocal, you have to have more than one PVC, right? Because you need to be able to compare them, okay? Now that contrasts to your conduction patterns in heart block, right? So if you have 3 P waves to 1 QRS, you would not, oh, you know what? We haven't even got there yet, have we? Don't worry about it. Scratch that out of your mind. There is special terminology for PVCs that sometimes come up. If every other complex is a PVC, we call that what? Bigeminy. Bigeminal. If every third complex is a PVC, we would call that trigeminal, and so on and so forth. Can we use this terminology anywhere else? No. We can use it with ectopic complexes. So we could use this with PACs, PJCs, and PVCs, but not the heart blocks. The conduction pattern with specifically the second degree, right? If you had 3 P waves to 1 QRS, you would not say that was trigeminy. You would say that was a 3 to 1 conduction pattern. You guys okay there? Cool. Okay, we talked about idioventricular or the ventricular escape. Okay, what differentiates these from junctional?
Right, QRS.
Good, the QRS tends to be wide. No P wave. Okay, slower, right? They tend to be much slower. Okay, now sometimes junctional rhythms can be wide, they can be slow, they may lack P waves. Okay, so when you're looking at it, you're just going to have to.
Junctionals can be wide?
Mhm.
Oh, I get one.
Yeah, what if you have a bundle branch block?
Yeah.
Yeah. So remember, when you sit down, you got to go, okay, where does most of the evidence point, right? Is this pointing? Let's say it's wide, and the rate is 30. There are no P waves. Could that be junctional?
Maybe.
Maybe, but where is the evidence pointing?
It's more
Pointing more toward a ventricular escape rhythm.
Ventricular is below 40.
Yeah, yeah, 20 to 40. Yeah. You guys okay? You guys okay with that? All right, good deal. And then we also talked about agonal rhythm, just an occasional complex here and there, also known as a dying heart. And along with that is asystole. All right. If you have asystole, what should you do to confirm?
Check multiple leads.
Check multiple leads to rule out fine V-fib. Good, and that also takes us to V-tac and V-fib. All right. You guys should know what V-tac and V-fib look like, right? V-tac, more than 3 PVCs in a row. We have 2 flavors of V-tac. What are they?
Monomorphic and
Good.
polymorphic.
Monomorphic and polymorphic. Okay, what's a common type of polymorphic?
Torsades diploid.
Right, TDP, good. Is associated with what kind of problem?
QT elongation.
Yeah, elevated QT interval. All right. Are you guys okay with treating critical rhythms? Are you okay with that? So if you have a tachycardia, what's the most important question you ask?
Symptomatic.
Good, stable or unstable, right? If it's unstable, you treat it with
Unstable
cardioversion. Unless it is an unstable torsades, then you treat it with
Defib.
generally defibrillation, right? Synchronizing may not be as effective. You guys okay there? If it is stable or not particularly symptomatic, then what other questions do you need to ask? Is- Right, is it wide or narrow though? Right? Are we dealing with a wide complex or narrow complex tachycardia? And is it regular or irregular, right? Because a wide complex tachycardia pushes us toward V-tac, a narrow complex SVT, and if it's irregular, that pushes us toward AFib, right, being the cause, right? You guys okay with that? Okie dokie. V-fib and V-tac without a pulse are treated the same, right? If it's a witnessed arrest, what can we do if we witness it happen right in front of us? Defibrillate immediately. If it's unwitnessed, we do CPR for 2 minutes and then analyze. All right, you guys okay with that? And then after every shock, what do?
CPR.
Go back into CPR and only check your rhythm after 2 minutes. So you're only checking the pulse every 2 minutes. You guys okay with that? Okie dokie, good deal. Good there. So then we went to lecture 5, talking about the 12 lead and the STEMI, and some of the STEMI mimics. Okay, so are you guys okay with the coronary arteries? What are the major coronary arteries?
Right.
So the RCA, what does it supply?
Inferior wall,
Inferior wall of what?
the right,
Inferior wall of
the right
what?
ventricle and the right.
No. Inferior wall of what?
Left ventricle.
Right, inferior wall of the left ventricle,
Oh,
right? And the right ventricle, and the right atrium, and typically the
posterior.
part of the posterior wall as well, and then
SA node.
the SA node, the sinoatrial node. Okay, good. What about the LCA, the left coronary artery? It has 2 major branches. What are they?
The left, the circumference.
The left anterior descending and the circ. LAD supplies primarily the
Septum,
the septal wall and the anterior wall of the left ventricle, right? The circumflex supplies the lateral
lateral wall of the left ventricle.
wall of the left ventricle.
Posterior.
Good, and then like the RCA, there's some crossover, and you can get some posterior as well. You guys okay with that? We talked about localizing, ST elevation, depression, hyperacute T waves, etc. We talked about lead groups, and we said I, C, all leads are ISAL, and I is inferior, okay, which is our RCA. What leads look at the inferior wall? 2, 3, and augmented vector front. Good. C is the septal wall. What leads look at the septal wall? V1 and V2. Good. All is the anterior wall. V3, V4. Leads is the lateral wall. That's 1, AVL, V5, and V6. You guys good with that? If you wanna look at the posterior wall, what do you have to do?
Do a modified 15.
Right, yeah, V7, 8, 9, or the modified 15 lead. And if you wanna look at the right ventricle, what do you have to do?
V4R.
Yeah, V4R is gonna be one of your most important leads to do. Okay, you guys good with that? All right. You're good with, what the implications of hyperacute T wave changes are? You get the tall peak T waves, first few minutes of the onset of a STEMI, and then, so you get, hyperacute T wave changes. Do we see that often? No. And then we get ST elevation, right? We can get ST depression. Depression indicates ischemia, elevation is injury. And then what's the other thing that can develop after hours?
The pathological Q wave.
Right, the pathological Q waves. All right. What is significant generally for ST elevation?
Wait, when is the?
What's our Q waves, pathological Q waves?
Days after?
Yeah, hours to days.
Hours.
Yeah. What are our thresholds? That we,
It's, 1 millimeter and
1
one
millimeter and
section.
2 or more contiguous leads, right? That means they have to be in the same lead group.
Right.
So if you had 1 millimeter elevation in lead 2 and 1 millimeter of elevation in lead V4, that would not be significant, right? But if you had a millimeter or more in 2, 3, that would be contiguous, right? So greater than 1 millimeter in 2 or more contiguous leads, or greater than 2 millimeters in a single lead. All right, you guys good with that? Pathological Q waves, generally greater than 1/4 to about 1/2 of the length of the QRS complex is significant for pathology. Do the Q waves ever go away? They typically do not, right? Typically do not go away. Does the ST elevation typically go away?
Yes.
Yes, it does. If it doesn't go away after a few months, then you're actually worried about something called ventricular aneurysm, if an aneurysm is developed inside of the ventricle. That's nothing we can detect out in the field without an echo, so, you know. There we go. Then we start talking about some of the STEMI mimics. What are some? Throw some at me. Benign early repolarization is a big one, right? What does that look like? What differentiates it from a standard STEMI?
It's got a concave, asymmetrical.
Asymmetrical T waves. Okay, good. Asymmetrical T waves. Possibly some concave elevation. And where do you see the elevation?
Like overall.
It's diffuse, right? You see diffuse elevation. Does that make sense? Whereas a STEMI, you tend to have it isolated to certain lead groups. And you have no reciprocal changes with early repolarization, right? Whereas with a STEMI, you can have reciprocal changes, and a reciprocal change is depression opposite of leads where you have elevation, right? Is that, you guys okay with that? Okay, good deal. All right, axis deviation and bundle branch blocks. Okay, so let's talk about axis deviation. The easiest thing to do is look at your limb leads, leads 1, 2, and 3. Okay, what would a normal axis look like? Up,
Complex.
up, and up, normal. How about pathological left axis deviation? Up, down, and down, right? And then how about right axis deviation? You sure? You guys agree, Jeremy?
Down, or is it down, up? No, it's down, up.
Look it up. Look it up if you're not sure. It's okay. That's why we're doing a review here.
V2 is
Down, up. Down.
possibly
Down,
down.
Down, down, up, up,
Down.
down, down, down,
Down, up.
down, up, up.
Oh, I was right.
It's
Down, up, up.
down, up, and up,
Just
right?
opposite of the.
Opposite of patho left. How about that, huh? Because remember, you're shifting to the right. lead 1 is a left-looking lead, right? 2 and 3 are more right, on the right side there, okay? And then how about extreme right axis or right shoulder? Yeah, that's easy. That's down, down, and down. Okay, good. Bundle branch block, what criteria do we use to identify bundle branch block?
Wide QRS.
Good, greater than 0.12 seconds. And how do we differentiate between right and left?
Transit.
V1.
Good, go to V1 and turn signal that bad boy. If it turn signals up, that is right bundle branch. If it turn signals down, that is left bundle branch block. Good deal. Guys okay with that? Cool. Okay, fascicular blocks, drug electrolyte effects. Okay, so fascicular blocks, you have a few different flavors. Let's talk about a left anterior fascicular hemiblock. What is that going to look like? What does it look like? What's a classic thing that tells us we have a left anterior fascicular hemiblock? Left axis deviation, right? What would tell us that we're dealing with a bifascicular block?
Left axis deviation and, bundle.
There you go, and a right bundle branch block. So the right, so you have your junction, your AV node, your bundle of His, you got your right bundle branch, you got your left anterior and your left posterior, right? So if I just blocked the left anterior fascicle like that, that would produce a left axis deviation and our LAF-HB. If I block the left anterior fascicle and the entire right bundle branch, that would give me a bifascicular block, right? And then finally, if I have a trifascicular, what is that? LAD plus right bundle branch block plus an AV block of any sort, right? So I'd have a block up here. All right, what about this fascicle? Does this fascicle commonly get blocked? The left posterior fascicle? Very uncommon, yeah, it's a very uncommon. But that tends to be right axis deviation, right? We see right axis deviation causing a left posterior fascicular hemiblock. Right, you guys okay with that? Why is this important? Because we can see our patients progress from this to this to this, and that tells us that their conductive system is failing and that we should probably put pads on and be prepared to pace if needed. You guys okay with that? Cool, drug and electrolyte effects. We talked about some specific drugs. We talked about digoxin and the dig effect, right? We talked about little mustachio, right? Little Salvador Dali mustache and the ice cream scoop depression. Okay, you guys okay with that? We talked about drugs that increase the QT interval, of course. Electrolytes, a major electrolyte we focused on was potassium, right? Are you guys okay with what hyperkalemia looks like? Okay, the classic finding is a tall peaked T wave.
And it's symmetrical, right?
Huh? And it's fairly symmetrical, yeah. It's not as asymmetrical as a benign early repul. You guys okay there with that? All right. Good.
And you'll see that in multiple leads, right?
Yes, you see that in multiple leads. What would differentiate that from, say, pericarditis? History. The PR segment gets depressed, and you have history, right? You have a fever, you have, some trauma, prior infection. That there's some history there, points toward. Okay, good deal. And then we talked about today the QT interval. You guys okay with that? I think, yeah, we just covered that, so there's really not a whole lot going on there. And that's it. That is your entire ECG course. Do you guys have any specific questions? So you're not going to have very tricky strips. I'm not giving you guys tricky stuff, they're gonna be pretty straightforward. It's about an even mix of 12 leads and rhythm strips, okay? Okay, the problems will be obvious, and it's multiple choice.
That's really
Yeah, so that should actually make it easier, it's multiple choice, right? About a third of the test is not rhythm strips, but rather it is asking questions. Well, what would you do if you saw this? And you might not necessarily have to give me an interpretation, but you'll have to know what it is to know what treatment to do or what not to do. There is at least one matching question, okay? So all the rest of the questions are multiple choice, but I believe there's one question that is matching. Okay, but again, it's pretty straightforward. And if you're comfortable with the stuff that we reviewed today, you're probably gonna be looking really good at going into the final exam. Okie dokie, guys? Let's see, it's about 1 o'clock. I don't have anything else, that give you a little extra time to study. Please let me know if you wanna stick around, and work on the monitors, and I'll stay in here.